بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. معكم دكتور ياسر طاقة, neurosurgeon. I'm going to give you the second lecture in neurosurgery for your fifth stage. In fact, as I told you in the first lecture, that I'm going to give you the most important notes and informations which every doctor should know in neurosurgery. I mean the basic neurosurgical principles which you must know. You will not be a neurosurgeon at now. You are going to be a general practitioner, and you must know the basic things regarding to neurosurgery. Our today's subject is cerebral edema and increased cranial pressure, or what we call as intracranial hypertension. And in the second part of the lecture, I'm going to talk to you about another subject related to this subject, which is what disease called benign intracranial hypertension or pseudotumor cerebri, which is also one of the causes of increased intracranial pressure. Now, to start with, I'm going to talk to you about cerebral edema. Cerebral edema are classified into two types, either vasogenic edema or cytotoxic edema. To start with, vasogenic, from its name, vessel, vaso means vessels, so that is originated from the vessel, while cytotoxic related to cells. Now, regarding the first type of edema, of cerebral edema, vasogenic edema. Vasogenic edema is the most common form of brain edema encountered in clinical practice. This type is due to increased permeability of the cerebral capillaries with resultant accumulation of plasma or exfiltrate to enter the extracellular space. And now I will concentrate on this part, extracellular space of the brain. Extracellular space of the brain. This type is seen commonly in trauma, primary and metastatic tumors, and focal inflammation like brain abscess, so that the fluid will be accumulated in the extracellular space between the cells. Extracellular space, I mean outside the cells, between the cells, the fluid will be accumulated between the cells of the brain and resulting in edematous brain. Now, the other type of cerebral edema is cytotoxic edema. Now, the problem is inside the cell itself. Derangement of cellular metabolism, which result in inadequate functioning of the sodium and potassium pump, leading to cellular retention of sodium and water and cell swelling. So that the swelling here is inside the cell, intracellular swelling, while the previous type was extracellular swelling. This type is seen in various intoxications like dinitrophenol or in Reis syndrome and severe hypothermia. Both these, I mean the cerebral edema, I mean the vasogenic edema or cytotoxic edema, are one of the causes of increased cranial pressure, I mean intracranial hypertension, which is our next subject. So that, to start with, I'm going to talk to you about the pathophysiology of intracranial hypertension. You know very well that the skull contents are the brain, the cerebrospinal fluid, CSF, and the blood inside the vessels, the arteries and veins and venous sinuses of the brain. So that any increase in any one of them, and in fact, before I'm going to proceed with my discussion to you, I'm going to tell you one word which I repeated many times in my lectures, that the skull is a closed box. Remember this, please, always, when I'm going to say to you, the skull is a closed box, so that this box is not extensible. In order to compare, for example, between the abdomen, we have the extensible skin, while in the skull there is no distension of the skull will happen after an increase in its size, in size of the contents of the skull, which are, as I mentioned, the brain, the CSF, and the blood. So that any increase in the size of the brain or its appendages, for example, the cerebellum, the ventricles of the brain, or the choroid plexus, for example, or the brainstem, will result in increased cranial pressure. Increase in the amount of CSF, while increased production or decreased absorption, accumulation of CSF inside the brain more than normal, will result in increased intracranial pressure as well. Increase the blood amount, whether due to hematoma or any other cause, this all will result in increased cranial pressure. The normal supine intracranial pressure is 5 to 15 millimeter mercury, which equal to 60 to 180 millimeter H2O. An increase in the volume of any of the contents of the skull, as I mentioned to you, I mean the brain, blood, or CSF, will result in increased cranial pressure, ICP. The brain ability to compensate for raised cranial pressure is rapidly exhausted, So that raised intracranial pressure is dangerous to the brain. Is dangerous to the brain. What will happen? There will be compression of the brain within this closed box, I mean the skull, so that the result will be a herniation of the brain outside the skull through, for example, foramen magnum, and this will injure the brain tissue and resulting in death of the patient. Now, regarding the etiology of intracranial hypertension, first of all, localized masses like hematoma, for example, extradural or epidural hematoma, subdural hematoma, and intracerebral hematoma. As I mentioned, increased size of blood. Neoplasms like glioma of the brain, meningiomas, and metastasis all will result in increased cranial pressure. So that here there is in the size of the brain. Abscess, brain abscess, now extra tissue is added to the brain. Let's say the wall of the abscess and the contents, I mean the pus, inside the brain tissue. Focal edema due to trauma, infection, and tumors all will result in increase in the size of the brain and increase in intracranial pressure, I mean intracranial hypertension. Obstruction to CSF pathways, and this will result in increase in the amount of CSF. As I mentioned to you, we have three contents, the brain, CSF, and blood. Now there will be increase in the amount of CSF inside the brain. And this will result either due to obstructive hydrocephalus or communicating hydrocephalus. And in fact, in the next lecture, I'm going to talk to you in detail about this important subject. Obstruction to major venous sinuses as a result of, for example, the brachial fracture over major venous sinus or thromboembolic disease from contraceptive pills, and this will result in increase in the amount of blood inside the brain and resulting in intracranial hypertension. Also, diffuse brain edema or swelling due to encephalitis, meningitis, diffuse head injury, subarachnoid hemorrhage, Rice syndrome, water intoxication from fluid overload, all these will result in increase in the size of brain due to either extracellular edema, I mean vascular, or due to cytotoxic edema, intracellular edema. Idiopathic intracranial hypertension, or cause sometimes pseudotumor cerebri, which will be the subject of our second part of this lecture, inshallah. This disease most commonly found in adult female patients and also called, as I told you, pseudotumor cerebri. Systemic hypertension can cause a breakdown of the blood-brain barrier and cause hypertensive encephalopathy, and all these will result in increasing the intracranial pressure, I mean intracranial hypertension. Now, as far as still we are talking about the pathophysiology and pathology of the increase in the cranial pressure, as far as there's increase in the size of the brain or increase the amount of CSF or increase the amount of the blood inside the closed box, I mean the skull, there will be this result in herniation, so that it is so dangerous to the brain to let the patient having increase the cranial pressure, so that treat him as early as possible, as early as possible, so that brain edema, if not, or I mean, in case the cranial pressure if not treated, will result in cerebral herniation. Cerebral herniation, we have in fact four types of cerebral herniation. Number one, called subfalcine herniation, below the falx. Number two, ankle herniation, the herniation of the ankles through the tentorial hiatus, or tentorial herniation, I mean brain tissue, brain stem through the tentorium. And lastly, tonsillar herniation, tonsil of the cerebellar tonsil through the foramen magnum. You can see in this figure, in fact, the four types of herniation. This one is the subfalcine herniation for this patient, for example, this hematoma, abnormal hematoma at here, causing mass effect and compression of the brain to the other side. And this one, number one, this is called the subfalcine below the falx, subfalcine herniation. This one is ankle herniation, the ankles through tentorial hiatus. All the brain stem through the tentorium, called tentorial herniation of the midbrain structures. And number four is the tonsillar herniation of the cerebellum through the foramen magnum at here. You can see, for example, in this one, in fact, each one of these herniations will result in some sort of abnormality or defect in the patient. This figure also, mass here is in the other side and causing subfalcine herniation or ankle herniation, transtentorial or tonsillar herniation of the cerebellum. This figure showing to you the subfalcine herniation by postmortem specimen, and this other picture is of MRI in coronary view of the patient having the subfalcine herniation. In fact, subfalcine herniation results in shift of cingulate gyrus of one hemisphere, the cingulate gyrus, to the other side under the falx cerebri, under this falx cerebri, and across the contralateral side of the brain. The other type of herniation is the ankle herniation, as I mentioned to you. Here will be the shift of the medial temporal loop medially towards the tentorial hiatus. There will be oculomotor palsy with a progressive contralateral hemiparesis, and this is the site of herniation. You can see this is normal, while this is herniating to the other side. This is called the ankle herniation, also seen at this ankle herniation. Then we have what's called tentorial herniation of the midbrain through the tentorial hiatus. And the last type is you can see at here is the following magnum herniation or called tonsil herniation. I mean cerebellar tonsil. In fact, normal cerebellum is this. The limit of it is just this limit. This is limit of normal cerebellum, while all this is cerebellar tonsil herniated through the foramen magnum, as you can see in this postmortem specimen. You can see this is an MRI sagittal view of patient having herniation. Now, the normal cerebellum will be just as the civil, while this cerebellar tonsil has been herniated through the foramen magnum. So these are so dangerous to the brain and may cause death of the patient, or as you saw, that may cause deficit. Now, after that, what are the clinical features of intracranial hypertension? In fact, there may be no any symptom or sign. Maybe the patient is having this increased intracranial pressure, but have no symptoms or signs, or maybe having headache. In fact, you must know a few facts about this headache. This headache usually worse at the morning due to vasodilatation caused by hypoventilation and consequent CO2 retention during sleep. So that this headache will be early morning headache. You can imagine it just like the following. Now, during sleep, all of us will be having a decreased respiratory rate, not like a waking patient. This will decrease wash of CO2 outside and gaining of O2 inside. And this will result in hypoxia and hypercapnia inside the brain tissue. Okay, but normally we can compensate for it and we don't not feel anything about it. While in cases of increased intracranial pressure, this will be exaggerated, and so that how will the brain will be compensated to get the oxygen more in this field of hypoxia. The heart will give much more blood to the brain. I mean, there will be vasodilatation in the vessels of the brain to gain more blood to the brain to compensate for deficit of oxygen. So this will result in increase in the size of blood inside the skull and increase intracranial pressure and hypertension. So that this there will be mainly at the evening, at sleep. At awakening, patient will be having severe headache at the early morning, at awakening from sleep. But with time, and he will awake and get more increased respiratory rate and more wash of CO2 and getting O2 to the brain, and then this headache will be gradually subside, not subside, but decrease in intensity. Nausea and vomiting, also a quite important feature of increased blood pressure, and the vomiting will be projectile vomiting, drowsiness, and altered mental status. I mean, disturbed level of consciousness, papilledema. And papilledema, in fact, this will result in a blurring of the disc margin as seen by fundoscopy. And in case of papilledema, why papilledema is happening? Here, for example, there is mass lesion. This mass will compress on the all walls of the skull, including the base of the skull. You know that the optic nerve is passing through the base of the skull to both orbits, and with this nerve will pass the blood supply to it and its venous drainage. There will be here a pressure on the whole collection, I mean, and on the optic nerve pressure, on the arteries, and on the veins. You know that which one will be closed first, artery or vein? Of course, the vein will be closed first. Artery will not close at first, so that what will happen? Blood is going inside but not returning back. There will be edematous optic disc, and this was impairing of vision. Sixth palsy was called as false localized signs, also due to coded displacement of brain stem, and so that is not a true localized sign. It is called as false localized sign. At later stages, there will be triad of bradycardia, hypertension, and respiratory irregularities, sometimes called as Cushing triad. right, in these later stages. In infants, you know, the infants have different thing that the skull is not so closed. There is still open fontanelle and open suture lines. Here in infants, there will be tense and bulging fontanelle. These are the most important clinical features of increased intracranial pressure. What investigations? Before investigation, you can see, for example, they show this patient having headache and vomiting and papillotomy. You can see blurring of the disc margin. They are not so sharp, clear like normal optic disc. What are the investigations? You will see the patient having increased cranial pressure. Of course, I told you in the first lecture, these are important investigations, include skull X-ray, computed tomography, CT scan of the brain, and MRI of the brain, magnetic resonance imaging of the brain. In fact, skull X-ray will not give me a strong clue about the final diagnosis. I mean, for example, brain tumor or something like that, but it will show to me the cardinal signs, which I'm going to talk to you about them, about increased cranial pressure. In CT scan MRI also will give me feature of increased cranial pressure, but these two will show the lesion if it is present. For example, spastic lesion, for example, brain tumor or hydrocephalus or some arachnoid cyst or cystic brain tumor or other brain tumors. Or everything will be, for example, brain abscess, everything will be apparent in these two. I mean, they will give me the size of increased intracranial pressure plus the causative agent for this increased intracranial pressure. In fact, in skull X-ray, we will suture separation in children. I mean, the coronal suture and suture will be separated as if there is fracture. A copper beating marking of the cranial vault. A copper beating marking of the cranial vault. In fact, copper نحاس. يعني هذا ذكركم بإيش؟ وعدكم قبل كانوا يستخدمون الأواني النحاسية في استخدام منزلي، يعني المواعين والطاسات كان كلها من النحاس. حال الحاضر يعني استبدل بالستيل والأمور الأخرى. ليش؟ لأنه هذا النحاس أولا كان سعره أغلى، وبعدين كان يعني وزنه كان أثقل، وتنظيفه ما كان سهل، وبمرور الزمن يعني اللمعة مالته تختفي، يحتاج كل فترة لازم يروحون يبدلوها أو يبيضوها، يعني يسموها تبييض مالها. حاليا ما مستخدمة، ما عدا فقط يعني في ما نقول في يخلوها في غرف استقبال كشيء من التراث، يضعوه على الميز كذا إلى آخره، يتكشفون بأنه عندهم أواني نحاسية قديمة. أوكي، فهذه شلون كانوا يعدلوها؟ ما يعدلوها بمكانها بالطرق. الطرق مكان الطرق مال نسميه القلم احنا عليها يترك اثر عليها، تشوف انه الحافات مالها من الداخل ما راح تكون سموث مثل الستيل، وين تكون كلها عباره عن برينتس اوف ذا هامر اوفر ات. فهذه اللي تخلي يعني السطح مالها ما يكون املس. ف as if the brain or I mean the skull will be beaten just like that copper beating marking of the cranial vault. Thinning of the dorsum cilia, and lastly erosion of the posterior clinoid process. These are the copper beating mark. هذه حاجة الألوان النحاسية السابقة أكيد شايفين عندها أو سامعين بها. وهذه عبارة عن skull showed you the copper beating marking. You can see that as if you are looking at the brain. These are the prints of the brain, the sulci and gyri. Normally not seen like this. They are smooth normally, but this integral pressure and continuous pressure on the brain and on the skull, sorry, of a brain on the skull, they will print on it. Well, somebody may ask me, how does this soft tissue, I mean the brain tissue, will do this erosion of the bone? Yes, it can cause it. يعني مثل ما تشوف قطرة ماء تنزل على صخرة على مرور السنوات تعمل تحفرها. ولهذا put in your mind that these features will be apparent in chronic increased pressure. I mean not for a few days. يعني مثلا واحد عنده سجينوماتوما أو سبجينوماتوما ما يعمل هالشيء هذا، مستحيل، إنما لازم يكون مدة أطول من العلاج. This is a typical skull X-ray showed to a copper beating marking of the skulls وشون كل هذه ما تكون يعني interrupted. Also you can see here the beats or the prints of the brain. This is the celetoscica. This is the posterior process eroded. هذا عندنا anterior process posterior eroded posterior process, and also thinning of dorsum cilia at this side of the skull. Now this is in fact a CT scan of the brain with a modality called bone window. You can see the beaten parts of the skull from inside by the increased cranial pressure. Also, this one, that one was in fact coronal view. This is axial or horizontal or transverse section of the skull by bone window of CT brain. You can see these are many prints, many of the sulci and gyri, I mean cover-BT marking of the skull. What about the treatment of increased intracranial pressure? I mean intracranial hypertension. To start with, we can divide this treatment into two parts. First of all, to treat the increased intracranial pressure as a whole. But secondly, to treat the cause of it, and will be the final treatment of it. Now, I will summarize to you the most important points regarding the treatment of intracranial hypertension. Number one, head position here. You will put the head and head elevation. By head elevation, you are using the gravity to draw blood and other contents, I mean the water contents of the brain downward outside the skull, and they result in increased the pressure, decrease the pressure, and they are in fact very, very effective. Number two, hyperventilation. Hyperventilation, in fact, to reduce the carbon dioxide level down to 30 to 34 millimeter mercury. Hypertonic solutions including mannitol and hypertonic saline. Mannitol is very well known in a concentration of 10 and 20%. It is an osmotic dehydrating agent used in dose of 1 gram per kilogram, and it acts by drawing water out of the brain tissue by osmotic forces. This reduces the brain tissue volume, and the increased pressure will be decreased. So that this is the mechanism of action of mannitol and its dose. Hypertonic saline clinical research support that it's to be as effective as mannitol. In fact, they are giving the patient, the normal saline is 0.9% normal saline. Here, it is about 50% normal, 50% concentration normal saline. Lasix furosemide, which is a loop diuretic, it acts by reducing the cerebral edema, reduce CSF production, and this is quite important point. And lastly, it acts synergistically with mannitol to reduce the increased intracranial pressure. Steroids, dexamethasone, in dose of 4 milligram, 6 hourly. It seems to be most effective in decreasing intracranial pressure resulting from vasogenic edema associated with the brain tumors, infection, surgical manipulation of the brain. A steroid, in fact, it will act by stabilizing the blood-brain barrier and reducing oxygen-free radicals and will result in decrease in the intracranial pressure. Other method is ventricular drainage. Ventricular drainage by ventriculostomy or by shunting. By ventriculostomy or by shunting, and this will result in decreased intracranial pressure. Barbiturates. Barbiturates will act by reducing cerebral metabolism. You know that how much you are working your brain, you will be in need for more and more blood and more and more food of the brain, which is mostly glucose, and how it will reach to the brain through the blood, so that you can notice on yourself that if you are going to think of many things, and for example studying and solving problems, and for example mathematical problems and reading and summarizing things, you will see that after a short while you will feel hungry. Why? Because the brain is in need for glucose, and to be taken from all parts of the body to the brain, and you will feel hungry because of decrease. So decrease in the blood glucose in the body used by the brain. But how it will reach the brain? By increasing blood supply to the brain. So that here what we want to do the opposite thing. يعني actually يريد الشخص ما يفكر، بالعكس انه يكون تقليل تفكير. decreases is brain activity. when we are going to be barbiturates ايش بصير عنده مثلا؟ يعني is going to sleep. He wants to sleep much more than need. With this is sleep, in fact, he will feel uh, no use of his brain, and then decrease in the need for glucose, decrease the blood supply to the brain, and result in decreasing temperature. Hypothermia down to 34 degrees is currently undergoing assessment as a brain protective agent. Lastly, last treatment, as I told you, to treat the causative agent of the problem, and that is by surgical intervention, including surgical evacuation of causative mass lesion like hematoma or neoplasm. A depressed skull fracture can also cause elevated intracranial pressure when it compress, for example, over superior sagittal sinus or any other sinus. so that removal of elevation of this depressed segment will resolve the problem. Occasionally, surgical control of ventricular pressure will involve large decompressive craniectomy, such as in traumatic brain injury or extensive middle cerebral artery infarctions. There will be generalized brain edema, and we are obliged to decrease ventricular pressure. All measures failed, so that what we are going to do decompressive craniectomy of large piece of the skull outside. And in fact, we are putting it in the subcutaneous tissue in the abdomen, and then to return it back when the patient is going to be normal later on. By this note, we are finishing the talk about intracranial hypertension. I'm going to talk next about other subjects related to intracranial hypertension, and that is what's called benign intracranial hypertension, which is, as I mentioned to you, it is one of the causes. It is one of the causes of increased intracranial pressure and intracranial hypertension. In fact, before I'm going to speak about this subject, to give you a few rapid notes about this disease, it is disease of unknown etiology, unknown mechanism of action. Nobody till now have definite things about this disease, but their all things will be just similar to increased intracranial hypertension. Even there will be papilledema. Okay, you will send the patient for any investigation. All investigation will be normal. So that is disease of exclusion. And the final diagnosis will be by measuring the intracranial pressure of the patient through lumbar puncture. After, you will be sure there is no mass lesion by doing CT scan or MRI, and you will see the elevated intracranial pressure. Also, I said again, of unknown etiology. And it will be treated by conservative methods if they feel that we will have some surgical aspects to treat this disease. Now, benign intracranial hypertension, also known as tumor cerebri, as its name implies, is disease of raised cranial pressure, which usually runs self-limiting course. When we said self-limiting course, it may resolve with itself without any treatment. Although termed benign, this condition can cause blindness due to severe papilledema. If it is not treated well or rapidly, it will result in blindness. The pathogenesis is poorly understood, as I told you. The condition is usually occur in obese females. Obese females يعني ذكركم دائما بالايش ما ذكرنا لكم ال 40 female, 40 fertile, etc. The feature of gallbladder as well. Now, regarding etiology, the etiology, as I told you, is generally poorly understood, and the exact mechanism of the raised pressure are not known. The condition is found typically in young obese women, often with menstrual irregularities or taking oral contraceptive pills, and an endocrine disturbance, as we suggested. In minority of patients, definitive precipitating cause is found. So that what I'm going to mention to you, number 1, 2, 3, 4, 5, are in the minority of cases as a definite cause for this disease. And by dealing with this cause, you will correct the increase in intracranial pressure in this patient. Number 1, hypoparathyroidism seen in some patients. Vitamin A excess used to treat acne. Pernicious anemia. Drug reaction, tetracycline found sometimes, nalidixic acid, sulfapentazole, indomethacin, danazole, lithium carbonate, oral contraceptive steroids are all as causes for this disease. By stopping these drugs, the patient will get resolved from increased intracranial pressure. A similar condition resulting from venous sinus thrombosis as well can be seen. Regarding clinical features of this disease, they are just features of increased intracranial pressure. Headache, as I told you, also morning headache, visual disturbance due to papilledema, headache, heavy features of intracranial pressure, in that they are worse in the morning and exacerbated by straining, stooping, and coughing. The visual problems result from papilledema or secondary optic atrophy, and diplopia due to 6 cranial palsy, as I told you just previously, that it is false localizing sign. What investigation you are going to send the patient with benign intracranial hypertension? In fact, the CT and MRI scan will show no cause for the papilledema, and the ventricles will often be smaller than usual. But sometimes you can see even the size of the ventricles is the same. I mean normal, not so compressed or not smaller. Digital subtraction cerebral angiography or magnetic resonance venography may be performed to exclude thrombosis of the venous sinus as a cause for this disease. If the CT scan or MRI shows no mass or lesion, then I repeat it again. If the CT scan or MRI shows no mass or lesion, then you can do lumbar puncture. Is usually performed. The pressure will be raised. And in fact, how much it will be raised? Normal CSF pressure will be, for example, between 150 to 180 millimeter water or CSF. In this patient, it will be elevated not just like, for example, 190 or 200. No, maybe, for example, 300, 350 or more. Usually performed, lumbar puncture, the pressure will be raised. CSF examination is normal in benign hypertension, but biochemistry and cytological investigations should be performed to exclude underlying pathology. Regarding treatment of benign hypertension is usually self-limiting disease, even without treatment. And most cases respond to simple conservative treatment. The usual measures are taken either medical treatment or surgical treatment. Medical or surgical treatment, as I going to tell you now. When we said self-limiting, put in your mind this quite important thing that yes, it is self-limiting, but if you diagnose a patient having this disease, yes, I tell him, go to home, no need for anything, no need for any drug, this is self-limiting, you will get the resolve of your problem within, let me say, for 2 weeks or 1 month or 2 or 3 months. No, this is not true. We must give him treatment. Because if you will not give a treatment, yes, the increased pressure will pass, but they may leave him with a blindness. So that treatment is quite mandatory. Regarding medical treatment of our case of hypertension, weight loss, the patients are usually obese. I told you, obese females. Stopping any medication that may have led to the disease, for example, contraceptive devices or contraceptive or tetracycline. Direct therapy also effective. Acetazolamide, which will reduce CSF production, also is so beneficial. And if there is no improvement with the above measures, a treatment with a glycerol or steroid may be tried for like dexamethasone, as I told you in the dose, for example, 4 milligram 6 hourly. If all these fail, and the patient is going to get blindness, we are afraid from blindness, then we are going to do surgery for this patient. The major indications in the indication for surgical treatment are persistent severe papilledema despite conservative measures, failing vision, or intractable headache despite conservative measures. Regarding surgical procedures used to treat this disease, we have two modes of surgery. Either optic nerve sheath decompression, what's called optic fenestration, or lumboperitoneal shunt. I just want you to know these things, their names. I mean, lumbar peritoneal shunt, shunt from the salon space in the back to the peritoneal cavity, and optic nerve fenestration, sequence decompression to treat to avoid blindness of these patients. Okay, with this slide, we are finishing our lecture today about increased cranial pressure and its accompanying disease of tumor cerebri. Thank you very much for listening. If you have any question, don't hesitate to contact me. I'm ready to answer these questions. Thank you very much, and meeting you, inshallah, in the next lecture.